Welcome to As a Woman, Fertility Hormones and Beyond. I'm your host, Dr. Natalie Crawford, and I am a board-certified OBGYN and fertility physician, and also co-founder of FFS-For Fertility in Austin, Texas. Each week on this podcast, I discuss health and fertility and how they relate to your true self. Become a part of the community of collaboration that amplifies others as a woman. I hope you enjoy the episode. You are listening to the As a Woman podcast. I'm your host, Dr. Natalie Crawford, and today we are talking all about your fallopian tubes. I get asked so many questions as a fertility doctor about your fallopian tubes, and there's a lot of misconceptions and a lot of myths out there about your fallopian tubes, the function of them, how you evaluate them, what does it really mean if one is blocked, can you get pregnant if only one is open? And today we're going to talk through a lot of these different variables. Before we dive in to talk about fallopian tubes and your anatomy, a couple updates. The first one is going to be, I love answering your fertility questions. So please remember that you can call the voicemail at 657-229-3672. Again, that is 657-229-3672. And you can leave your voicemail question. The voicemail is going to allow us to really answer the questions that you may have. There's no dumb question. And I know sometimes you don't even know what episode to listen to have your questions answered, or you may not know what questions you have until somebody else asks them. So again, that's 657-229-3672. In addition to the voicemail, you can also ask your questions on Instagram at nataliecrawfordmd. Every Monday, you can ask your question on Instagram in the question box, and some of these questions will be answered right there on Instagram. Some will be answered at the end of these podcast episodes, and some questions will be answered in our weekly newsletter. So remember that we have a newsletter. You can sign up for the newsletter at nataliecrawfordmd.com/newsletter. And the newsletter is going to have exciting updates, very soon going to have some freebies, so you're going to want to sign up for it. And I have some very exciting news coming, but it also has recipes, some of my favorite things, and fertility in the news, and fertility questions. So it's just a great little nugget to come to your inbox to keep you up to date and for us to connect. In addition, this episode is coming off of Pinnacle Conference. And if you don't know what Pinnacle is, if you've been following me for a long time, it is a conference for all women in medicine that I am one of the founders of. Pinnacle is an amazing experience in the medical profession. There is so often a lot of competition, a lot of jealousy, a lot of holding each other back, feeling like there are limited seats at the table. That was 100% the environment in which I was trained and I was raised in my medical training. And we are working hard to fight that narrative and truly believe that we can do more together. Pinnacle was absolutely amazing this past year. It was in Austin, and this coming up year in 2025, it will be in Austin also, May 16th through 18th. So if you are a woman in medicine, you can be a physician, a nurse, a PA, a dentist, a physical therapist, a pharmacist. It doesn't matter. If you want to work on community networking, leadership, communication skills, business skills, it is for you. It's one of the most incredible weekends of my professional life. I love it every time. And we will sell out. So we're already selling for 2025. If you're not in medicine, but you have somebody in your life that is, it would be a wonderful thing to share with them. And you can find out more about that on my website, nataliecrawfordmd.com, or on the Pinnacle website, pinnacleconference.org, and we have the lowest price. You can save $450 if you sign up before the end of May. So sign up ASAP. All right, well, we are going to dive in now and talk about the fallopian tubes. So I think that everybody has probably heard about the fallopian tubes, which is why it's so interesting that there is so much misunderstanding about the tubes. If you think about your uterus, I want you to think about, we always imagine the uterus is fixed inside our body, but it's really not. The uterus is more like a potted plant. So you've got roots at the bottom, and that's really the cervix and some of the uterine ligaments that keep the uterus rooted down in the pelvis. From the uterus extending up on each side becomes the muscular component of the uterus. So you have the outer layer, which is called the serosa, that's smooth and silky because it interacts with your intestines and everything inside your abdominal cavity. You have the myometrium, which is the muscular layer of the uterus. And this is the area where you're going to get those cramps or contractions when you have a period or if you go into labor. This is what allows the uterus to stretch and to grow and to hold a pregnancy. And inside the uterus, you have the endometrium. The endometrium is the layer that you're going to shut off every month. It responds to hormones, both in growth to estrogen and compacts to progesterone. And so that is a very hormonally dynamic system. When it comes to the fallopian tubes, what's really interesting about female anatomy is that you start with two Mullerian buds or ducts. These are tissue segments, and you have two of them next to each other that elongate as you are a fetus growing inside your mom, and then they fuse together, and then the midline portion that connected these two segments reabsorbs. And these segments form the upper 1/3 of the vagina, the cervix, the entire uterus, and the fallopian tubes. So there is something called Mullerian agenesis or Meyer-Rokitansky-Kuster-Hauser, and this is where you have complete failure of these Mullerian ducts to form. Women are born with ovaries still. Ovaries are a completely different embryological origin. So you have ovaries, but you have no fallopian tubes, no uterus, no cervix, no upper vagina. You do have a vagina. It just ends in a blind pouch and goes about 2/3 of the normal depth. And that's usually diagnosed by having what we call primary amenorrhea. You don't go through the full spectrum of puberty. So you go through the normal onset with hair growth and breast development because your ovaries are making estrogen. But because there is no uterus, you never have a period. So typically these girls are diagnosed between 16 to 18 when they present because they've never had a period. And then they find out that they don't have a uterus and therefore don't have tubes. Very fascinating is that we can now do a uterine transplant. And having Mullerian agenesis or being born without a uterus is one of the top indications to be a recipient of a uterine transplant. And in that circumstance, you would go through IVF. Your eggs would be taken out of your ovaries, paired with sperm in a lab, and embryos would be made. You would then undergo the surgery to have a uterus transplanted. And then you would be on immunosuppressants so you don't reject the uterus, but can then have a transfer and get pregnant. And you do get the uterus removed after 1 to 2 pregnancies pending the goal because we don't want somebody on immunosuppressant medications forever and ever. Why are we even talking about Mullerian agenesis in an episode about the fallopian tubes is because you can be born without them. You can have no uterus and no tubes. You also can have a unilateral uterus. So this means one of those Mullerian ducts did not form at all, but one did. So you actually have the top of the vagina is normal and you have a cervix, but then you have a tubular uterus, just one half of it, and one fallopian tube. But you do still have 2 ovaries. There's also something called a didelphys, where you have these 2 completely separate sides. They just never fused. That's a circumstance where you have a fallopian tube on each side. You, of course, still have an ovary on each side, but the uterus is duplicated. So you have a tubular uterus on one side and a tubular uterus on the other, and you actually can see 2 cervical openings on a speculum exam. Very interesting. In these abnormalities, you often don't have any symptoms, meaning until we are undergoing an evaluation of your anatomy, we don't know that you might have one of these birth defects that can impact your ability to get pregnant. You have normal periods, you have normal puberty. So sometimes there's truly no signs or symptoms that something could be going on. You also have a higher chance if you have these of having endometriosis, so scar tissue. So if you have a fallopian tube, it also has a higher chance of being scarred because of the inflammation from endometriosis, but then also a higher risk of having kidney abnormalities and also vertebral or skeletal abnormalities or scoliosis. So just very fascinating overall. When it comes to tubal factor, when we think about the fallopian tube, so many people think about the tube as being nothing more than a highway, a connecting zone for the egg and the sperm to get together. A lot of people don't actually know that the tube has a very important job and that the environment of the tube and the function of the tube is a lot more than just a transport highway. About 30% of all people who have infertility have tubal disease. And that's not a small number when you think about the fact that 1 out of 6 have infertility. When it comes to the tube, it's important to understand that the fallopian tube is muscular and it connects to the uterus, and that section of the tube is called the interstitial area, the portion of connecting the tubal environment to the uterine environment. Then you have the isthmus, the ampulla, and the fimbria. The fimbria are the end of the tube that are a little more wide and open, sometimes can look like fingers. The fallopian tube does not attach directly to the ovary. The ovary is separate, and the fallopian tubes move around. The ovaries move around also. The ovaries are anchored to the pelvic floor and to the uterus, but they can move around. And as a follicle grows, or you're preparing to ovulate on one side, that ovary is going to become enlarged. Now, the fallopian tubes, if everything is functioning normal in your body, they do move, and those fimbria ends almost act like a catcher's mitt, trying to get close to catch the egg. The egg is released from the follicle rupturing. So each egg grows inside a follicle. A follicle is a fluid-filled structure you can see on ultrasound. Any fluid-filled structure is a type of cyst. This is a follicular cyst. When you ovulate, what happens is the brain interprets that you have a mature egg based on the estrogen signal, and then you have the LH signal coming from the brain based on that high estrogen, and LH causes that follicle to rupture, and the egg is released, and it's released into the abdominal cavity. We call it the peritoneal cavity, and then the fallopian tube is supposed to be hopefully close by so that it can scoop it up. So the tubes do move around. And the short answer is if you don't have one tube, the other tube can move around. There's a huge misconception that if you lose a tube, but you have both ovaries, that you can only get pregnant when you ovulate on the side that you have the fallopian tube. And that's not true at all. Now, if the tubes are stuck or you have tubal disease, then that adds an extra dimension because the tubes should be free flowing and they should move around. What causes most of the tubes to actually be damaged? A lot of this is due to inflammation. And the inside of the tube actually has cilia. So when you think about cilia, think of them almost like little hair-like projections that all work with these muscular contractions of the fallopian tube to be able to push the egg and the sperm together. So it's not just a passive highway, it's more like a conveyor belt. In addition to being a transport system, it actively helps egg and sperm meet. It also, the environment of that tube is very important because the process of fertilization happens in the fallopian tube. That egg is released from the ovary and it only lives for about 24 hours. So that sperm has to get into the fallopian tube within that 24-hour of egg release. Luckily, though, the sperm can live for up to 5 days in the female reproductive tract. And that is why that fertile window is not just one day. Yes, the day you are ovulating or the 24 hours after ovulation is going to be your most fertile time, but sperm get to that egg so quickly and they can live a longer time. So putting some sperm there beforehand is also advantageous if you're trying to get pregnant. So right now, when we think about the tube, yes, it is a highway per se, but there is cilia that help propel egg and sperm together. There are secretory cells that make secretions that actually aid in supporting the sperm and the egg. And there's peristalsis, little contractions of the fallopian tube. And those are actually influenced by hormones, estrogen, progesterone, and prostaglandins, which are released after ovulation. So all of this is a very interesting functional system working to bring the egg and the sperm together so they can be fertilized in the fallopian tube. When we think about tubal disease, I always like to think about there are different stages. So you have just bad tubal environment. Tubes might actually be normal if we're checking are they open, but remember that none of our examination is actually checking the functionality of the tube. I can't see if the cilia are working or if it's having these little contractions. I can only see is it open or not. So our evaluations of the fallopian tube are limited in what they can do. But you can have a tube that just has the environment that is more toxic to egg and sperm. Remember, even if the tubes are open, the ends, those fimbria, are open to the peritoneal cavity. So if you have appendicitis, for example, your appendix is inflamed, you have a lot of inflammation, that inflammation is also going to get into the fallopian tube. So if you're trying to get pregnant that month, that's not going to be a very suitable environment. Eggs and sperm are very fragile. Also, any inflammation can lead to scar. So we worry that even that one case of you having that ruptured appendix back when you were 22 can cause you to have permanent tubal damage. Having an abdomen full of pus, an abdomen full of blood, that absolutely can get into the fallopian tube. So you can get the environment acutely can be abnormal due to current inflammation. The environment can be normal or not now, but prior inflammation may have led to tubal blockage. And there's different types of blockage. So there's blockage of what we call the distal end, down by the fimbria, where the catcher's mitt is. And then there's blockage up closer to the proximal end, or the interstitial area, the entry portion of the tube to the uterus. And they actually have different prognostic factors. And then you have more, even a worse case, is a blocked fallopian tube at the distal end that is also dilated. And this is called a hydrosalpinx. So when you look at having a blocked tube alone is one thing. Having a blocked tube and a dilation or a hydrosalpinx is another factor. And so these all have various stages of damage or risk. And then, of course, you might have one fallopian tube gone. So maybe you were born with a Mullerian anomaly and you don't have that tube, but maybe you had an ectopic pregnancy, you had the tube removed, maybe you had ovarian torsion and that caused the tube to be removed. So there's reasons why you might be limited in not having both fallopian tubes that are functional. But as we go through this, one thing I always say is if we think it's a toxic environment, or if we see one blocked fallopian tube, especially if we don't know why. You had ovarian torsion, which means you had a cyst, the ovary was enlarged and it twisted upon itself, therefore obstructing the blood supply to the tube in the ovary, and you got that ovarian tube removed. I know exactly why you only have one tube. However, if I find out your tube is blocked on some of the diagnostic testing, which we're about to run through, and only one is blocked and one is not, your tubes are open to the same peritoneal environment. We are probably mistaken to think that one tube was exposed and damaged to the point of blockage and the other tube is perfectly normal. It might be open, but it might not be perfectly normal. And depending on what you see and what tests you do, you might get more information about this. The number one top cause of fallopian tube blockage is going to be history of having an infection. So specifically chlamydia or gonorrhea, that can cause a tubal infection that damages the fallopian tube. But other type of infections, such as an abdominal infection, like the appendix or any type of bowel infection, having tuberculosis, any inflammatory disease such as endometriosis, that can also cause scar tissue inside. You can see things like prior abdominal surgery, prior bleeding inside. So there's a few different things that can all contribute, regardless of if it's in the tube itself or the peritoneal cavity. And then there's also tubal spasm, which is sometimes a blockage on screening evaluation that is just due to actual muscular spasm of the fallopian tube and not due to an actual blockage. So depending on the screening evaluation, you might see spasm, and this is almost universally proximal tube disease. So when you have the opening of the fallopian tube that appears to be blocked, so you don't see any of the dye or the bubbles go into the tube at all, it is more likely to be proximal tube spasm versus spasm anywhere else. Because if you see the dye enter the tube and then it stops, the things that impact the fallopian tube more commonly are further down closer to the end. The end of the fallopian tube, that is always more severe blockage and more real. When we see that blockage on evaluation, we know that that's actual blockage. And then you have how do you evaluate it? So the types of evaluation for fallopian tube include an HSG, a hysterosalpingogram, a type of a saline water test, which can be a FemView test or a saline sonogram with a bubble test. There's a few different words. And then there's surgery. You can do laparoscopy with putting dye through the fallopian tube. So the HSG is actually an X-ray test. So this is going to be the test that out of the operating room evaluations is going to give you the best tubal evaluation. You put a speculum in the vagina and you put a catheter into the uterus through the cervix. And then you inject dye into the uterine cavity, and it'll show you the inside of the uterus and also the fallopian tubes. You can watch the dye move through the tubes and then come out the end. The in-office version of this, which is with an ultrasound, is sometimes called a FemView or a hysterosalpingo contrast ultrasound. But this is essentially where you put a speculum in the vagina, a catheter into the uterus, but then you inject saline into the uterine cavity. You'll see the uterine cavity distend. Definitely a better evaluation for the inside of the uterus, because if you see something abnormal, you know what it is. And then you inject air bubbles and watch them come through the fallopian tube. And there's some newer ones or different ones that have gel or other particles that can go through the tube and then get absorbed. That is another evaluation. Both of these have to be done at a very specific time on your cycle, because you don't want the uterine cavity to have such thick lining that it prohibits dye or liquid or bubbles from going through the interstitial area and entering the fallopian tube. So for most people, this is day 6 to 10. If day 1 is the first day of bleeding, 6 to 10 is the time period after you've finished bleeding, but before the lining gets thick enough closer to ovulation. With a big asterisk, if you have shorter cycles, your cycles are every 24 days, you very well might ovulate on day 10. So you might have to be seen even earlier. But on average, you would call with day number 1, and then these tests would be scheduled between day 6 to 10 or while on birth control pills, because birth control pills keep the lining of the uterus really thin. Remember, we want to get a good enough evaluation so we can see what's going on. The other option for us is to do surgery, and when we're doing surgery, this is laparoscopy. So you're putting a camera inside the abdomen through the belly button. You're asleep, you have to get anesthesia, and you're injecting carbon dioxide so that you can get the abdominal organs away from where the camera is. You have already put a catheter device into the uterus through the vagina, and then you usually connect this to blue-colored dye, and you push this blue dye through the uterus while you watch with the camera up above, and you can see the dye come out the ends of the fallopian tube, and that's called chromotubation. So both the HSG and the saline tests are about 85% good at diagnosing abnormalities. This is one of the circumstances where when it's open and normal, it's normal. But if it's abnormal, sometimes it's very clear what it is, but sometimes you need further evaluation. For laparoscopy, that's always going to be the diagnostic standard, what we call the gold standard, because you're using your eyeballs and you can see something better. However, it has more risk. You have to go to sleep. You have to put a camera inside. No surgery is benign or without risk. So that's not something that everybody undergoes, especially not anymore. When you do laparoscopy, one of the nice things is that you can also see if there's other things contributing to the tubal disease. Is there scar tissue in the abdomen? Do you see endometriosis? Are the tubes in a normal position? So you do get more information, but we've really, as a field, gone away from doing laparoscopy due to the fact that it does carry some risks. The other testing methods are very good and effective, and actually history can give you a lot of good information. So just talking through somebody's history. All right, so now that you potentially have a tubal blockage, what do you do about it and what does that mean? So if we look at ectopic pregnancy as a good example, two of the different options you can have is a salpingectomy, removing the tube, or a salpingostomy, which is actually where you cut an incision and you take the pregnancy out and then that incision is repaired. And so studies have tried to say what is the best procedure if you are found to have a tubal pregnancy. And there was a study published in JMIG, the Journal of Minimally Invasive Gynecology, in 2021. So that's a really good journal. And the take home is this was a review. And so in the two randomized controlled trials, these were low risk patients, and there was no difference in subsequent intrauterine pregnancy between people who had the tube removed and those who did not. Meaning you can have a tube removed and you still have a good chance of getting pregnant again, the same chance if you still have the tube in place. And then what about the blockage found on HSG or on a saline, sonogram, FemView, or at surgery? The real answer here is it depends on where the blockage is occurring. So The difference in proximal and distal tubal blockage is large here, meaning that distal blockage that originates from inflammation at the opening of the fallopian tube where that catcher's mitt is going to have much more significant consequences than proximal blockage, which potentially could be spasm. So numerous studies have looked at unexplained infertility and comparing those rates of success with unilateral tubal blockage and then stratifying for proximal obstruction versus distal. So a single fallopian tube that has potential proximal obstruction or spasm should be treated the same way as unexplained infertility, and they have the same chance of conceiving with ovulation induction IUI or superovulation as option 1 and IVF as option 2. However, distal tubal obstruction, even if it's only on one side, is not the same as unexplained infertility. This is tubal disease, and the other tube is at risk of having some difficulty in function, even if it is physically open, because the rate of success with IUI and ovulation induction, that first-line treatment for unexplained infertility, is very low, and distal tubal obstruction should go on to IVF. If we think about the cause for distal obstruction, again, infection and inflammation. Top cause is going to be chlamydia, gonorrhea, endometriosis. We know that in endometriosis studies, even surgical management of stage 1 and 2, that very early onset disease, and then proceeding with an IUI doesn't have any added benefit over just doing the IUI itself, has the same odds of success with unexplained. And in stage 3 or 4 disease, that really severe destruction of anatomy, then you're in the circumstance where IVF is going to be the option. So that's further proof that you don't have to go to surgery to figure out if the tube is distally blocked or to try to open it up or to try to have more success with IUI, because that surgical intervention carries risks and time and money, and it's not changing the odds of your outcome. So again, where the tube is blocked makes a huge difference in what the next step should be. Proximal blockage at the opening between the uterus and the fallopian tube, is likely or potentially spasm and not pathologic, and should be treated as unexplained infertility if it's only seen on one side. If it's bilateral, then you have to presume that this is bilateral tubal disease and proceed with IVF. If you have unilateral blockage distally at the middle portion or the end of the fallopian tube, that is concerning for pathologic disease such as prior infectious or inflammatory etiology, and now you're in a circumstance where IVF will be your best bet. In addition, complicating all of this is that nasty hydrosalpinx. A hydrosalpinx is a distally blocked tube that has become dilated with fluid, yet it is still proximally open and connected to the uterine cavity. This fluid sits inside the fallopian tube and it can't go anywhere except inside the uterus. And what we see is that it makes a toxic uterine environment, and even in the setting of IVF, it decreases the odds of success with an embryo transfer by 50%. So if you are found to have a hydrosalpinx, we then need to go to surgery and take that fallopian tube out, or at least disconnect or block the tube so that it no longer connects to the uterine environment. That way you have the highest chance of getting pregnant. This is also why it is important to evaluate the fallopian tubes even if you're doing IVF. And I don't always recommend evaluating them from the beginning. If you're just getting fertility testing done, a tubal evaluation is 100% part of the workup. If you come to me and there's a sperm factor, or based on your age or other reasons we're choosing to do IVF, we may not do a tubal evaluation off the cuff. However, it is an important component before we go put an embryo inside, especially if you have risk factors like prior infection or symptoms which could be concerning for endometriosis, like painful periods or pain with intercourse. My favorite analogy is to imagine the fallopian tubes when they're functioning like normal as that little blow up that stands outside the mattress sales place or the car dealership. It is filled with air and it wiggles all around, and the arms of the tubes are just like that. They move around where the egg is released and try to swoop it up. So just losing one tube itself does not mean that the other one cannot function. However, I'm always asking, why did we lose the tube? Is that a process that we think impacted the other fallopian tube? And where might we have tubal blockage if we're only seeing one fallopian tube blocked? Where is that blockage? What could be causing it? And how does that impact our entire process? I hope you enjoyed learning a little bit about your anatomy and the fallopian tubes. And now I want to answer some of our questions. Again, this is our For Fertility's Sake segment, FFS, and this is our weekly Q&A where you ask questions and I answer them. You can ask these questions on Instagram on Monday at nataliecrawfordmd. Some of the questions will be answered there on Instagram, some will be answered here on the podcast, and some on the weekly newsletter. Don't forget to sign up for the newsletter at nataliecrawfordmd.com/newsletter. Fertility in the news, Q&A, recipes, updates, lots of fun freebies coming your way soon, so sign up. You can also call and leave a voicemail at 657-229-3672. Again, 657-229-3672. Let's get to our first question. Other than genetic abnormalities, what can cause multiple chemical pregnancies? So very early pregnancy loss is definitely number one attributed to random genetic abnormality called aneuploidy, but potential other causes could be still genetic, something called a balanced translocation. That's not random at all, and you can detect that in your own chromosomes. You can also have endocrine disorders such as thyroid disease, autoimmune disease, prolactin abnormalities, insulin resistance. All of that can contribute to early pregnancy loss. We also can see implantation issues, which often can be associated with more of those inflammatory conditions, potentially PCOS, endometriosis, adenomyosis. And then we can have some ovulatory issues. So certainly that plays into whether you're having delayed ovulation or you're having more of some hypothalamic dysfunction, having some luteal phase issue, but not ovulating from the best follicle is not going to give the best base to make progesterone. So there's a variety of things that can cause very early pregnancy losses. Not as common. Typically, a later cause of pregnancy loss is going to be those clotting disorders. So things like factor V Leiden or antiphospholipid antibody syndrome is typically not presenting with chemical losses. You're getting a little bit further before those placental blood vessels are getting clotted off from clotting disorders, but that is a part of the workup. And similarly, so is an anatomical issue, one of which could be a uterine septum. So as we described earlier in the episode, how the uterus forms in these two different buds and fuses together, failure of reabsorption of the full midline piece is resulting in a uterine septum. Uterine septum is the most common birth defect of the uterus, and it's associated with an 80% chance of a pregnancy loss. These pregnancy losses can be returned back to normal, meaning that rate can drop dramatically if you get the septum repaired. So an anatomical evaluation is a huge part of a recurrent pregnancy workup. And I always remind patients that recurrent ectopic pregnancies or tubal pregnancies are a real thing that can present as multiple chemical losses as well. So another reason why evaluating the uterus and the tubes are both very important. Next question is how to support embryo implantation in IVF when I have endometriosis. Endometriosis is an inflammatory disease which is autoimmune in nature. Your body has an abnormal reaction to a normal process, resulting in high levels of inflammatory markers. That inflammation can be toxic and can make it a lot harder to get pregnant. The base of this disease is really stimulated by hormones, and that makes it really hard to get pregnant because you need estrogen to grow a lining to implant a pregnancy. So if you do IVF, which a lot of patients with endometriosis do have to do, I'm a huge fan of leaning towards controlled or medicated cycles, and I really love suppression so that we are suppressing these endometriotic lesions prior to the transfer. That can be with Lupron, microdose. It can be with Depo-Lupron, so longer dosing, with or without letrozole. It can be with Orlissa. So there's different medications we can use, but truly believe that we need to drop the stimulus of these lesions before we go and give you estrogen to try to grow the lining. And I see really great results with those. How many miscarriages are too many? I'm at 5 without a baby. I'm so sorry for all you've gone through. I certainly have been through many miscarriages myself. So has my younger sister, and we've been really, really open about it. The short answer is that after 2 losses, you should get an evaluation. The evaluation includes what we said before: endocrine, hormones, check for autoimmune, check for clotting disorders, anatomic evaluation, check karyotypes of you and your partner. That workup used to be after 3. However, we have made that sooner because at this point we want to catch more people. When we do this full workup, probably only 15% of the time do we find a cause, meaning 85% of the time it's unexplained for current pregnancy loss. Depending on how far the loss is getting is answering some of the question. I certainly find that IVF covers a lot of this. So when we don't have a reason and there's nothing much to change and we're still having recurrent loss, sometimes we just need to grow those early embryos in a totally different environment. And this can only be achieved with IVF lab. The lab is not toxic, there's no inflammation, it's the right temperature and pH. And because that is where egg and sperm meet and early embryo growth occurs, in the fallopian tube, that environment really does change according to your body and the world around you. So sometimes we really just do need to get egg and sperm to meet in a different environment. And then we have to do genetic testing, really find out which embryos have the highest potential in order to be able to make a difference. So even when we don't really know what's happening, which is so frustrating, IVF does treat so many different factors. 5 miscarriages is too many. You definitely need an evaluation. And if we can't find a factor, strong consideration for IVF. All right, friends, well, I hope you enjoyed the episode. I'm so thankful for all of you. Again, you can follow along on Instagram at nataliecrawfordmd. Check out the YouTube channel for short form videos, and you can call and leave your own voicemail question at 657-229-3672. Thank you, friends. Thank you all for listening to As a Woman. It would mean so much if you could rate, review, and follow the podcast to be notified of new episodes every Sunday. I hope you learned something new, and I hope you share it with someone in your life. Be sure to follow along on Instagram at nataliecrawfordmd and check out the YouTube channel Natalie Crawford MD. If you're interested in becoming a patient, you can also follow FFS Fertility. I'm so thrilled to have you here, part of the community that amplifies others as a woman.